Ladies and gentlemen, good afternoon, good morning, and without Cameroon Society of Vaccine and Public Health. We're thrilled you're joining us for part of this show and interact with the community in the southern Cameroon. We hope we will leave you with a lot of information and have a lot of your questions answered. We looked out there and there's been a lot of as we release this topic. The panel is very rich with healthcare providers that should be adequately knowledgeable to address most, if not all, of your questions today. For those of you watching us through our different broadcasting channels, Facebook or YouTube, please do submit your questions because we will be happy to address the majority of them today. Our panelists today do include Dr. Edmund Folefac from Ohio State University, and Dr. Edwin Shadzeka for those of you who watch Dallas. Ladies and gentlemen, YouTube, please do submit your questions because this is a bi-weekly event that is brought to you by the Southern Cameroons Medical Society, and we hope to maintain the schedule. Dr. Edmund Folefac, the majority of them today.
Thank you very much, Dr. Dr. Fausta. Glad to be here to share my knowledge with our folks on the ground. Good evening to all of you listening to us from Bazonia, from around the world, and you're welcome to the Southern Cameroon Medical Society.
And we hope. Thank you very much, Dr. Dr. Shadzeka, please welcome.
Dr. Dr. Fausta, knowledge with our folks on the ground. Good evening to all of you listening to us from Bazonia, from around the world, and you're welcome to the Southern Cameroon Medical Society.
Right, Dr. Edwin Shadzeka, you're welcome.
Thank you, friend, for addressing some epidemiological issues, and we hope we are able to inform, educate, and communicate on these very important healthcare issues today. Thank you.
And thank you very much. Ladies and gentlemen, that is Dr. and Dr. Two of our medical practitioners from the Southern Cameroon that will be informing you today about one, public health, and two, vaccines in general. Without much ado, please let's address today's topic, and then we can then step back and see if there are other burning issues that we'll be focusing on the health and healthcare experience of Southern Cameroons. Before we delve into vaccines, maybe we spend a little bit of time understanding what's the role of medicine, public health. Can you help our audience, dear panelists, understand what public health really is? Dr.
I think there's a lot of people in the background, and I'm not sure how panelists, our audience is actually understanding us. And I didn't really quite get your question, Dr. Fausta. If you can repeat the question, please.
Thank you again, and dear audience, today we are discussing the interaction, the intersection between medicine, public health, and then further on in this conversation would focus more on vaccines and the role of vaccines in improving the public health. Before we can then zoom in, it's nice to get a big picture of how medicine interacts and fosters the health of the public. And to make sure that our audience is on the same page with us, it's always important to get some key definitions and understanding out of the way. And so the very basic question to everybody who's watching is, we're talking about vaccines, we're talking about public health. What is really public health? And what informs public health policy is the first step at breaking this down to our audience, Dr. Folefac.
Yeah, thank you, really, Dr. Fausta again. So the interaction between public health and and actually health in general is a very interesting one. For those of us who sit in the clinic as doctors, we are trained to deal with one patient at a time, treat one disease at a time. But then you realize that there is a much bigger picture of how diseases patients eventually go from being sick to presenting themselves in the hospital. And the way I always think about it is that the best way to treat a disease is to not have it in the first place. And the way to not have it is prevention. And public health is that part of medicine, that branch of medicine that deals with this prevention. And you can look at it as those preventions are at multiple levels. The first is how to prevent somebody from not getting a disease in the first place. The second thing is when that person has had the disease and gone into the hospital, how are resources distributed equitably so that people actually can get the care they deserve at a price that will not, break the budget of society. And once those people then get treated, the next question is, how do you do what we call secondary prevention? You've had the disease, you've been treated, but how do we prevent that disease from you getting that disease? And in cases where they are communicable diseases, we're asking the question, how do we make sure that you don't spread this disease to other people? And the non-communicable diseases like cancer, diabetes, and stuff like that, again, we're asking ourselves, how can we prevent the community from getting it? And then how can we, once they get it, how do you treat? And then when you treat, how do you prevent it again from, how do you make sure that the people who are getting it, you limit the number and limit the complications that could come from this disease. So public health is actually critical in this big intersection. And one of the last things I would say is public health is actually community health and it's economic health. You cannot separate the public health from the economic health or even the social health of society. And COVID-19 has actually illustrated this very, very well, whereby you realize that if because of the COVID-19, which is a disease, you lock down society, there is no way that society can actually continue to produce and manufacture things and run the economy the same way that it used to do before. And if you actually start running the economy, COVID-19 comes back. And so you're trying to balance this real dilemma, and which tells you that, again, public health and economic health, they are like conjoined twins that are joined at the hip. And if a patient is not healthy, they're not going to go to work. If they are not healthy, if the entire country is not healthy, you end up spending a lot of money trying to treat sick people, trying to not get people who are so sick they cannot go to work. Fewer people then actually are left in the economy pool. And even those that are in the economy pool cannot produce maximally. And therefore, the whole community suffers. So public health is a very, very, very critical piece of society. And I think that I will leave it at this point. Eventually, we'll go into I hope we'll probably have time to actually look at some of the issues that go into public health, especially for a country or like ours or the continent of Africa, whereby the resources are, first of all, very not there. And public health is actually the cheapest way to deal with these diseases. We cannot wait until we get to the levels where the developed world is, and continue to deal with, take money that we could have used to treat one person. That we could have used to treat or prevent 1,000 people from getting a disease, to treat one person that we may not even heal in the first place. So as an oncologist, I think I need to know a thing too about, expenses in terms of care, and then we can talk a little bit more about that. Thank you.
Thanks very much. So I'm gathering from you, public health is the well-being of the society. And when it comes to public health, there are two layers. There is primary prevention and secondary prevention. Dr. Edwin, can you enlighten us a little bit more, looking at public health, the well-being of the society, and then also breaking it down some further, primary prevention and secondary prevention. And since our focus today is actually vaccines, where does vaccines fall on this continuum of primary prevention and secondary prevention, Dr. Edwin?
Well, thank you, Fausta. Thank you also, Dr. Edmund, for talking so broadly on these issues. Public health and public health policy go hand in hand. And we usually think of public health as the science and the art of disease prevention. So it's about improving the quality of health, not just for the individual, but for the entire community. You promote health, you promote good practices that improves health, and then you maintain the health of the community in the short term and in the long term. In doing these things, there's certain core factors which come into play, and we cannot discuss public health or the designing and implementation of public health policy without examining some of these factors. And those primary issues usually include assessment. We have to begin by making good assessment of the situation on the ground. That involves monitoring the health, making diagnosis, doing a proper investigation of dignity. And this brings us on the issues of public health, which are different in every community, whether it's in the USA, in Africa, or in the Southern Cameroons. There are specificities to that community, which requires and demand designing public health policies which respond to those specificities. So after initial assessment, then you develop a health policy, which involves information, kind of education, and a constant communication back and forth with the public and the stakeholders involved in the implementation of that policy. And of course, after implementation, we go back to re-evaluation and re-strategizing to make sure that the policy is fine-tuned. All of this is done within the context of a public health system, within the context of building a public health policy which is workable, and of course with the goal of preventing and promoting good health. And that brings me to the issue of what drives the policy. What are the issues which drives either the primary or the secondary prevention of diseases? I think Edmund talked about these things, broadly, but I'll just pick on a few. Health policy, as well as health development for the individual and the community, is determined by a few issues. Um, Offhand, I can think of social and political issues, economic issues, personal behavioral issues, environmental issues. And we're talking now about health, and we're talking about the Southern Cameroons. And the most important thing which strikes us is that we have a degeneration of the political and economic system, the social, political, and economic system, as we are undergoing through some kind of a disintegration of our political structure, affect the implementation implementation of public health policy.
All right, ladies and gentlemen, that was Dr. Edwin Shadzeka discussing public health policy, primary and secondary prevention. And listening to Dr. Edmund and Dr. Edwin, one of the key things that come up, or the key question I'd like to then immediately pose to them is, it appears there is nothing, no such thing as a universal public health policy. Can you elaborate? Is there something like a universal public health policy? And in what situation will that become applicable? And use that in that context to once more then talk about what will inform a public health policy, for example, in the southern Cameroons, using specific situations in the southern Cameroons. Dr. Edmund.
So, Foster, I think just along the lines that Edwin was mentioning, when you talk about universal, you're actually asking the question or some kind of a global public health policy. Yes, there are certain items that are applicable. You know, just like when you get your disease, when you get your patient, think about your the public as your patient. You know, there will be things that are really like common to every patient when they come to you to see you. But you know, but then there are some certain things that are specific, certain diseases that are specific to certain patients. And even when those diseases are specific to certain patients, the treatments that you may recommend may be different in certain patients depending on the resources available, depending on the health, the individual health of the patient, what they can tolerate and what they cannot tolerate, and all of that. Now, that said, so if you think about global health like that, you say, oh, I mean, public health in those general terms, for something like some very, very basic things like, you know, food self-sufficiency should be a public health issue. The quality of food or that we eat should be a public health issue. That is global. That is things that are really like common to. Then you think about drinking water, and all of that. You say, oh, I mean, public health in those general terms. For something like some very, very basic things like. First, are you getting an echo back?
I think there is delay broadcast. We're getting you. Go on.
Okay, so I was saying that some of the things are common to all societies that the public health should focus on. Things like drinking water, good sanitation practices, the healthy eating, exercise. All these things are common to every community. But when you then come to some of the other issues, like if you go to Southern Cameroon, for instance, and you take a public health budget, and I'm going to look at diseases and I say, yeah, there are more communicable diseases there, things like infection, than there are, say, you know, chronic diseases, for instance, diabetes and so on, and cancer. So a lot of the money, if you're designing a public health policy in Southern Cameroons, you're going to focus a lot more resources on, I mean, on things like on infection prevention, hygiene, and things like that. But if you were actually in Europe, those things have actually become almost the norm, like safe drinking water, or you and me here in America. Anywhere where you open a tap, you find very clean water. But that's not the same thing for somebody in Southern Cameroons or in Amazonia. So these are the things that you therefore are unable to, you don't really like when you're designing this healthcare policy, therefore you hone down on the specific things afflicting that particular community. One of the other things you see where I would really focus on in Amazonia more or than say in America is there are some things that are so that we have had right. Either maybe because of our the lack of resources. We've had things about food, what kind of food to eat. We've had it right. But in Amazonia, for instance, many people would think, oh, hamburger are the way to go, or this fast food. They look at it, they romanticize about fast food and hamburger. You and me know, probably for the last maybe 5, 6, 7, 8 years, you haven't eaten a fast food because you know that these things come with disease. But yet, the vegetables that are there in our system, if we are able to do all of that, and we can, encourage people to eat more of that, then that is a public health issue, in addition to the hygiene. These are the things that can actually impact the health of the person. And I would mention one last thing. Think about the WHO definition of health as the state of complete physical, psychological, and social well-being, not just the absence of disease and infirmity. And there is too much to unpack there. That means just the fact that somebody doesn't say, I have a fever, or somebody doesn't actually, have shortness of breath or cough and things like that, doesn't mean they are not sick. If you don't have a job, you are sick. You're not healthy. If you actually, with all these guns that are around, people being killed, the trauma that some of these people are facing, it's a public health crisis. If you look at some of these kids who would grow up, will be traumatized forever. And then you look at the things like people who are in not going to school now. If you don't go to school now for the past 4 or 5 years, for the past 4 years that kids haven't gone to school, the chances are that you will not be able to have an education. And as you don't have an education, your ability to provide for yourself and your family in the future is completely limited. And so the next public health challenge would be thinking, how do you manage all of that? How do you bring all of that to make sure that we design policies in the future to capture all of those things in order to make our community or our society healthy? So I think these are the things that people just hear public health and they just think that, it's as easy as just preventing people, as just, maybe designing a few policy about where to put a hospital and so on and so forth. Roads infrastructure, for instance. If you notice, a lot of the people who get sick, they get sick because food is being sold along the road. And the roads are very, very, the place is very dusty because the roads are not tarred. This roads not being tarred means that there is a lot of dust that settles on this food, cause people to be sick, or flies that actually perch on food and then come, on feces around the way, perch on the food, cause people to have a lot of sicknesses that could have been prevented.
Wow.
And so there is too much. Or even if you have a good hospital in Bamenda and somebody is in 4 hours and there is no road and it will take them 3, 4, 5 days to get there, that woman is pregnant and did delivery. That's not a healthy situation. So when people think about public health, there is a lot of things to really unpack on this, and that's something that we can talk about for 3 hours straight, and we will not even be able to exhaust it. So I'll leave it here just so you kind of have that broadening of the way that we need to think.
So ladies and gentlemen, if you're just joining us, you're listening to the Southern Cameroons Medical Society discuss public health policy, and we're going to hone in on vaccines in particular. If you've listened to our two discussants, Dr. Edmund and Dr. Edwin, they've emphasized that the well-being of the society is a cornerstone of public health. If I'm also listening to them well, they've also emphasized that certain things are going to be universal and certain things are going to be region specific. And universal things may shape universal healthcare policy, but regional specific things are going to shape policy that's specific to the region. Let me use an off example. Food is a universal thing. It doesn't matter where you are in the world. Food is an important aspect of your well-being. So that's a universal aspect of public health. Malaria, for example, it's a tropical disease. It's typical of people that live around the equator. So malaria is going to be viewed by people that live around the equator as a public health concern. So, ladies and gentlemen, if you're just joining us, this is the Southern Cameroons Medical Society presenting vaccines and public health and well-being of our communities. Dr. Edwin, we've now discussed public health, we've discussed its universality and some of its areas being specific. We're going to then unpack how does public health apply to vaccines. First, is vaccinations. One, what is a vaccine? And two, do vaccines target primary or secondary prevention, and how is that? Dr. Edwin, starting with you. You are mute.
Thank you, Dr. Fausta. Can you hear me now?
5 on 5. Go on. 5 on 5. Go on.
Very good. Thank you very much. During my last discourse before the internet interrupted, I was transitioning into the fact that understanding the public health and designing appropriate public health policies is important and one of the keystones to actually make sure that the health of the community is promoted and improved is vaccinations. Vaccinations are very important and they serve as a primary tool in primary prevention of multiple infectious diseases, and in fact they're shown to be amongst the very most important effective preventive measures in public health strategies. However, with Edmund, we have significant barriers to the administration of vaccines, and these barriers are not experienced only in developing countries. We have difficulties here also in the USA and other developed countries. I'll just touch on a few, to address the questions you raised. Some of these barriers are more important in southern Cameroons in Africa, and the first one will be the lack of infrastructure, lack of delivery systems in the public and the private healthcare domains. We see that all over southern Cameroons. We don't have designated vaccination centers which inform the public and carry out regular campaigns for routine vaccinations. We also have patient and provider misconceptions about vaccinations and their adverse effects, and these sometimes conspiracy theories are very popular, and the need to we as healthcare providers need to step forward to inform and educate our patients about the reality vaccines and actually the rarity of complications due to administration of vaccines. We are in the last few months we've been talking about the COVID and the issue of the development of a vaccine, the risk of safety issues and efficacy issues. Even if we have a vaccine in the next few months, would it be good enough? Would it be well tested? So those are also some concerns which raise fears in the implementation of vaccinations. So I would like to conclude as a member of the Cameroonian Medical Society, we promote the administration of vaccines. We think that vaccines are effective, safe, they can be well monitored. We endeavor, very important, to separate ourselves and the administration of healthcare from the politics and focus only on the mental and physical well-being of the people, whether of South Cameroons or of Africa, in the administration of health. We, however, concede that the stakeholders in healthcare policy design and administration should be aware of certain things and be aware of the difficulties and the barriers in the implementation of vaccination programs. In the case of Southern Cameroons, you cannot carry the serum vaccination in one hand and carry the gun in the other hand and expect the community to come to you for administration. So we have to acknowledge the futility in engaging a healthcare campaign which requires very difficult and engaging educational process with the community. You cannot engage such a campaign in an atmosphere of socio-political strife and in administering that campaign in a foreign language. Those are the realities which bring healthcare policy, healthcare education, and the actual administration of these policies on the ground important. And I'm glad you asked these questions because we touch on so many issues. We touch on public health, we touch on policy, we touch on implementation, barriers to implementation, and what we can actually do to address these challenges. Thank you.
Thank you very much, fellow discussants. And this has been quite informative. To economists, I'm hearing my discussants saying there are a lot of strata in which public health policies can be implemented. And in every society, there is a scale of preference. And guns may be a higher scale of preference for the well-being of the public than a vaccine. And there is also an ongoing concern that potential politicization of the process can lead to conspiracy theories that deviate from the good practices of medicine. Today, as we touch on all of these things, we as professionals from the Southern Cameroons Medical Society would leave you with the science. We'll leave you with the medical recommendation. And then we'll touch on these things that on the periphery can influence the good practice of medicine. And as medical professionals out there, listen to us. We urge you to separate the politics from the well-being of your patients, from the well-being of your community, and from the well-being of society, so there can be existence of mutual trust and the lack of conspiracy theories, because that gives you the best chance to optimize the healthcare outcomes of your patients. Dr. Edmund, my audience is still asking, what is a vaccine? And how do we get to have a vaccine? What is the process? How do we get to have a vaccine? Can you tell my audience, how do you get to have a vaccine? How does it get from the lab of a biochemist to the hands of a pharmacist to be administered at these healthcare or these vaccination centers that Dr. Edwin touched on, Dr. Edmund?
Right. So let me go back a little bit and ask and just talk about vaccines, and I'll walk you through how this actually gets done. This is something that I do as a day job, clinical trials. Now, for vaccines, to understand vaccines, how vaccines work, you need to understand how our immune system first, how our immune system protects us. Now, think about our body as a small city. The immune system, our immune system would be like the sum total of all the security apparatus or the security agents within that community. So that it's the role of our immune system to really seek out the bad guys and actually get rid of them. Because there are more bacteria out there than we really can see. We're literally swimming in the pool of infectious agents, and many of these things have been around, longer than we humans have been around. So they know us, they know the environment, and they're much better than we do. And so our body has actually evolved a very complex mechanism to actually, prevent us from this disease. So when our body first get, so there are two kinds of, you can think about the immune system and divide it into two. What we call the innate immune system, which means we are all born with, and then what is the adaptive immune system, which is something that our body eventually gets to train itself as we grow. Now, when your body encounters a bacteria or a virus, in the case of COVID, what happens is your body, the immune system, quickly the innate immune system, your innate immune system goes after this infection and then try to get rid of it. Now, in the process of getting rid of it, what the immune system has actually learned over the years is that the innate immune system can only work for so long a time before it gets overwhelmed. So it would take on average between 10 to 14 days for you to develop your adaptive immune system. Your adaptive immune system composes of the T cells and B cells, we call them, that's how they are named. And so within that period of that 10 to 14 days, your body can actually get overwhelmed and die of the infection. And even if your body doesn't get overwhelmed at the first time, your body eventually could get exhausted. And so the immune system devises this trick to say, okay, the infection comes in with after fighting it, then the immune system then identifies small snippets of those that infection, which we call them antigens. And those antigens, therefore, actually a subset of the body's immune cells that are called the T cells, the memory cells, then take this, go to the body then manufacture standby army to fight that infection if they encounter it the next time. The next time when you encounter this infection, all of a sudden it doesn't take you 14 days anymore, to really bring this heart-hitting adaptive immunity into being to fight this infection. So it is that which the body, that's the trick. And it is understanding this that has led to vaccine development, to say, okay, we cannot wait until we get infected by very bad guys or very bad bugs before, in order to even train this, to train our immune system, to fight this infection. It will be almost as akin to a country waiting until they are invaded by some very dangerous, powerful enemy before then they start going to train their own military. No, you want to see what weaponry your adversary has and develop and build your capacity to be able to, so that if you get attacked, even at night, you get up, you have something to defend yourself. So that thing is vaccines. Vaccines are really a process of training our immune system, to fight our battles when those enemies eventually arise. And there are you can divide those vaccines into probably about 3 groups or 4. One of them would be what we call the live attenuated, which is you take that particular virus or infective agent, take the weakened, find a weakened point of it. You make it less likely to cause disease, and then you inject it into the person's body to fool that person to producing the immune responses and build this capacity, just that, so that if the next time when the real infection gets in there, then the body then already has enough to go and fight. The problem with that approach sometimes is that some of those weakened infectious agent in people with low immunity, like older people or people who have been sick, may eventually reactivate and then cause disease in a very small number of people. The next one is the dead, vaccine. The dead organism that you can take. You can take them and then put them in the person, inject them in the person's body as well, so that they don't cause disease, but then they fool the body to produce the immune system, the immunity that is required. The problem with that approach is that sometimes the immunity that it generates is not really strong enough to be able to last for too long. The third one is what we call the component vaccine. You take this whole big organism, find just that component of it that is actually causing disease, and then you use that to produce to fool the body, to produce the vaccine which you inject, and then it fools the body to actually believing that it is under attack, produce this standby army, and then the standby army comes. When the reinfection comes, then the standby army fights it. Now, that is a very, very novel approach. The last and most advanced one is what they're now calling the DNA vaccine. And what the DNA vaccine is like, it goes into our body has certain things that we call genes, and those genes are like the decode, like the program. It's like the instructional manual. So you can find the genetic code of that particular infection that we're trying to prevent. Use that to then give it to the body, and then the body produce the vaccines. Then that particular instructional manual, genetic code now, actually causes our body to produce this antibodies that we're talking about to stand by in case of an attack, and then to protect us. That is actually the gold standard, because in that, without one, the idea there is that it's going to generate a lot of antibodies, but without causing disease. And it is very interesting to actually know how we go from the animal or from the lab when the scientists, the basic scientists, to produce these things. The first thing that they want to do is actually to show that, oh, those things are safe. So there is a very, very long process that actually, with very, very stringent regulations to make sure that that is safe in the lab. Then they now test it in animals, to at least two classes of animals, maybe a dog and a cow, or maybe a dog and another, or a rabbit, two forms of mammals. That means these are things that may mimic the human condition. And then they see that they are safe. Then they take it now. Those two places that we're talking about, we call them preclinical trials. Then you take them now to something that we call phase 1 clinical trials. In that group, you're looking for healthy individuals who are in very, very small in number, who can actually, you can put it in them. In the case of COVID-19, you are saying, okay, if we put this in the people, does it actually even generate the amount of antibodies that we think will protect them in case these people were exposed to COVID-19? Then if you pass that level, you go to the phase 2. In the phase 2, it takes a lot of more people. And you then say, okay, now we know that it's safe, it's not going to kill anybody, it's not going to hurt anybody, but does it actually even do what we are asking it to do? Then you then go to the phase 3, which is like, in the case of COVID, it's going to be thousands and thousands and thousands of people. As of now, currently, the WHO, under the WHO, there are 9 candidate vaccines that are under WHO portfolio that are anywhere from preclinical to phase 3 clinical trials. And there are other 9 that they are screening, to include to those, so that all in all, we have about 18, but you can hear everybody from everywhere. There's so many of these things in different labs, but they have to undergo certain safety conditions in order to actually even move from one level to another. So I think that is the process. It's the most rigorous process I know. And as a clinical trialist myself, in cancer, it would surprise many to know that we're also finding vaccines to treat cancer. And indeed, we're using vaccines to treat cancer now. But that is a very, very rigorous process. The training you undergo, the testing, the fact that the reporting, how you get these things reported at all levels, and all the paperwork that you need to fill, you just people would be amazed. It's one of the most rigorous things that you have got to undertake, bar none. And you miss one step there, and then you can really be dinged from it. I mean, including being sued. For legal, for legally, you can be sued about that. So this is no joke, and our people really just need to really understand how safe vaccines can be with these things that we're talking about. So I think that's really what I really wanted to talk about in terms of the process, what is a vaccine, and the process, which is what of getting it to the office, to the hands of the people who are using it, as you asked me. Thank you.
Thank you so much, Dr. Edmund. Ladies and gentlemen, if you're just joining us, you are listening to public health and the vaccines presented to you by the Southern Cameroons Medical Society and hosted by Mr. Lambert Baum, the Executive Director of the Southern Cameroons Medical Society. We have been discussing public health in general, and now we are focusing on vaccines. You just missed it. Dr. Edmund actually said vaccines is a way of getting the body ready to prevent you from the real deal. The vaccines is a way of getting you ready for the real infection when it hits your door, so you're ready to fight it. And Dr. Edmund also expounded on the fact that there are so many candidates that we start out with. and not all of those candidates would end up because of the rigorous process that they have to go through. And he also enlightened us that there are actually multiple kinds of vaccines. Some of them are live, some of them are dead, and some of them are just components of the bacteria, all meant to get your body to be ready, so that when it sees the real deal, it's ready. Dr. Edwin, we keep talking about from the test tube to the patient, and many of these would fail along the way. Help us understand this rigorous process. What's the control? How do they get to pick who gets a vaccine, who doesn't get a vaccine? How do they evaluate it, whether it's effective or not? How do they do the studies? And when they do the studies, can it be generalized? Can I do a study, for example, on malaria in America and apply the results in malaria in Cameroon? We're talking about COVID, which has been around for a year. What can you say about malaria? What can you say about typhoid? What can you say about cholera? Dr. Edwin, please, the audience would like to hear your take about from the test tube to the patient, vaccines in general, and then in a context that's specific to those from the Southern Cameroons. Ladies and gentlemen, it appears I have lost Dr. Edwin briefly. So, Dr. Edmund, I'm cycling right back to you until we can get Dr. Edwin back on the show. You just heard
Edmund and Edwin, right?
Edmund and Edwin.
So now I will just wish to be Ed, right?
Yeah, I'll just go with Dr. Ed. So yes, from the test tube, you discussed 18 targets, and clearly all 18 will not become effective vaccines. You also discussed the rigorous process that it goes through. So you are by this telling our audience that there is a fine control that goes from the test tube. It goes through to animals, and we have to make sure, one, it is safe, and then we transfer it to people and we make sure it works. And even when we make sure it works, we have to monitor people throughout the vaccination process to make sure it's safe. Because we start out with a few hundred, we end up with thousands, and then we end up with maybe millions receiving the vaccines. Educate our people, because this topic of vaccine has raised a lot of dust, especially in the context of COVID-19. Dr. Edmund.
Yeah. So let me get back to giving you a two sentence brief history. 1796 was actually when an astute physician back then called Edward Jennings actually found out that, so that's when the first vaccine is credited. That's who is credited for developing the first vaccine, and was against a very, very deadly disease called smallpox. Then there was a sister disease in animals and cows that afflicted cows called cowpox. Now, what Edward Jennings actually observed, and this was actually what fascinating people then in England or in Britain, was that the smallpox left its victims with a lot of scars on their bodies and made their skin look very ugly. But there were these women mostly who were milking cows, and some of them who were like shepherds and going after cows, but they never had their skin completely always looked good, and people were like fascinated. What was read around about these people? Now, this is what genuine Edward Jennings actually, he made a leap of faith and said there must be something about that milk. There must be something about that cow that was protecting these women, and he actually took a cow that was actually infected with cowpox, and took some small serum from it, and injected his own godson, 8 years old then, right, to prevent him from, and that's how he cured that boy.
His son.
Yeah, his godson. It was his godson. It wasn't really his son, I think. So that's how the first vaccine, and lo and behold, he cured that guy of smallpox. And then that's how vaccines actually came to be developed. As soon as vaccines were developed, became more prevalent back in the 20th century, because of the poverty, many countries in the developing world were really still children dying of a lot of disease. If you think about what I told you about the innate and the adaptive immune system, when we are born, you have your innate body system, but you need over the years to train your adaptive system to fight infection, which is the reason why many kids who are exposed to disease die. The adaptive system is so weak, the immune system at that time is so weak. They haven't been exposed to many diseases that can train the adaptive system to go after those diseases. And so it became very critical, and 1 out of every 3 infants born in Africa was dying. So which means that you, Edwin, and myself, if not for vaccines, one of us will not be alive today.
Wow. So
I just wanted to just give me 1 minute, the expanded vaccine process program in Africa I think that was 1974, that the WHO actually brought this expanded vaccine program against such diseases like diphtheria, tetanus, tuberculosis, polio, and measles. This is actually what saved a lot of us. And if you realize now, nobody talks about smallpox anymore. Polio, which probably even at the time when I was young and you were young, you probably would have seen some of your friends who actually who were limping because of the polio that caused them to, that infected them and paralyzed them. So these diseases have actually, some of these, polio was they just celebrated the eradication of polio in Africa, recently. I think it was past 2 weeks or 3 weeks. So these things that we're talking about, apart from clean water, vaccines are by far, bar none, with the most effective thing that has actually saved human life. The only other thing that may come close is an antibiotic called penicillin, which is another, but then vaccines actually outpaced penicillin. So in terms of, its effectiveness, in terms of its cost benefit to society, there is just absolutely no comparison whatsoever. And anybody there who is actually talking badly about vaccine, it's that vaccines have become a victim of their own success. When you succeed so much, you take it for granted. So many diseases that have been killing us in Africa, and vaccines have now helped to eradicate those diseases. Now we kind of take for granted because we no longer see those people die. And unfortunately, COVID, right now, we've actually had about 1 million COVID victims in Africa. And probably because we're far under testing, the number of deaths in Africa is estimated at just several thousands. Again, probably I think it's based on the fact that the records are not as well kept as in the Western world. If you then say we get the vaccine, and you are going to say that these are probably, amongst all of these people, when you vaccinate the number of people who would need to be vaccinated, we are probably going to save thousands of lives and eliminate so many people from getting, complications from COVID, even if they survive it, and prevent all this economic lockdown and disruptions and stuff like that. So it's just kind of shocking to me and made me sometimes quite angry when I find, some dim-witted, morally bankrupt physicians. And I'm very surprised. And I have to use this word because I really mean what I'm saying. If you're a physician and you are still talking ill about vaccine, you really need to be able to go actually ask yourself, do you, number one, read the science? Or number two, if you read the science, do you actually put the interest of your patients and the community in the forefront? Because if you do these two things, then you should never have a bad word to say about vaccines. Yes, there are clearly things that we should fix about vaccine. I think Dr. Edwin was touching on some of them, which is the delivery process. making sure that some of the vaccines, when they are being delivered, they are delivered safely. Because some of the vaccines, for instance, in Africa, we did notice that in delivering some of them, if you use needles that were not sterilized, yes, you could use contaminated needles and give people some kinds of some infections that they did not have. So that's not a problem with the safety of the vaccine as it's a delivery process itself. So we also understood, in a very one of the other things I didn't mention when I mentioned phase 1, 2, 3, I should have mentioned phase 4. Phase 4 is, okay, the vaccine is already there, it's actually widely in use. Then if there is a problem that is spotted somewhere, then we continue to collect this data to inform us about what is actually, if there's a problem that was not previously anticipated. If we find something that was not previously anticipated, you pause, you go back to the drawing board. And this has happened to a couple of vaccines over the years, whereby sometimes they actually claim, oh, maybe this vaccine causes this Guillain-Barré, or this vaccine causes an infection, and blah, blah, and so on. And what then happened is that the company pauses and,
get more data.
Yes, get more data, go back to the lab, see whether those processes are being followed, whether there was no contamination, and so on. The only one that I am aware of was back in 1955, when vaccine was at its infancy. And part of the live attenuated vaccines, the polio live attenuated vaccine, some of it actually did cause, there was about 250 patients out of the millions that had actually had vaccines, that the polio actually reactivated in them. And that forced the regulatory bodies to the drawing board, who then went back to the drawing board and did more safety and said, okay, to the companies, to everybody, and said, there is a compensation plan just to make sure that you actually extend the carrot and the stick, so to say. That means we are going to do
the good outweigh the bad.
Yes.
So when you're looking at the public, there is this possibility that not everybody would come out on the winning side, you're saying.
Yeah.
But it's incumbent on us to do the studies. Let me recap on a couple of points that Dr. Ed, you struck on. Medically, when we say here is an effective vaccine against a disease, a physician, a medical practitioner will be morally bankrupt to teach that vaccine in favor of conspiracy theories. And you are also affirming that the delivery process could be faulty, and that comes down to one, administration, or two, the politicization of a good product. And so, ladies and gentlemen, we here of the Southern Cameroons Medical Society want to separate the medicine of vaccines, which is an excellent development in the field of medicine, from the administration or the politicization of a vaccine, which is something that may not totally be in our control. So we want to fix that. But when it comes to a vaccine that's made it to the market, know that for it to leave the test tube to the patient, it's undergone a rigorous process that's proven and tested since the 1700s. And so a physician, a medical practitioner who does not think well of their patients is morally bankrupt in withholding an effective, proven vaccine. Ladies and gentlemen, one other thing Dr. Edmund talked on, going back to the 1700s, is he emphasized on this concept of some vaccines are really the virus in its weakened form. And he used the eloquent example of cowpox and smallpox. Cowpox, in a way, it's a weakened form of smallpox when it comes to us. So those shepherds were being exposed to cowpox. They beefed up their immune system so much so that when they were eventually exposed to smallpox, they were protected, and they never ended up with those scars. Thank you very much, Dr. Edmund, for shedding more light to our people regarding what these vaccines are. Based on what you described, phase 1, phase 2, phase 3, apparently there should really be no difference between a vaccine and a drug. It looks like vaccine is what we call primary prevention, and a drug is something that becomes secondary prevention. Dr. Edmund?
I think Actually, there is more rigor in vaccines than drugs, than the regular drugs. Okay, because, and the reason is that, think about, vaccines are going to be given to millions, billions of people. So that's not the same way that most drugs are going to be limited to a few millions of people, right? Vaccine is the only thing, that's the only drug that's going to be given to billions of people. And so there is a lot and lot of safety input that goes into the development of these vaccines. The thing that actually annoys me, as you talk about, just talking about the politicization, is when, you know, politicians actually want to co-opt a process that is supposed to be driven by facts and facts alone, by data. And then you want to then actually, you know, make it a political process. And the fear there is that when you do that, even if you get the best, the safest product and the most effective product, you already actually eroded confidence, because then you in a way, you are actually making the case for the conspiracy theories for them, you know, or giving them more tools. And the reason why I get so angry with this is that if the people who would otherwise not have died, who would otherwise not have actually suffered these debilitating diseases, eventually suffer from it. And so the so-called, I mean, for Christians, they will think about sins of omission and commission. Which is more dangerous? I mean, are they different? In my view, none, not different. Especially when your omission is actually not from the point of not out of ignorance, but it's out of mischief, or to gain certain advantages or so. So that's the problem. That's why I get so, nothing upsets me like that. I know how much time I put in for my patients to find out what is right and what is not right for them. So to kind of like see somebody throw politics into the process actually really makes me mad. And I'm it's something I cannot help. Yes, it's something I cannot help. It's but I want to say that and then think about it also, that the tiny little babies, these kids are innocent, right? Why we actually, sometimes some people say, oh, it's my right to not take a vaccine. Yeah, but it's not your right to kill a baby.
That's right? Correct. That's very correct.
It's also your right to kill a baby. So you go talk to the mother of that baby who carried that baby for 9 months in her womb. You go talk to that baby, let that baby grow old enough to be able to have the faculty to reason, and then you tell him or her that it was your right to kill them, right? So because you denied vaccines. So I have to make sure that we need to really make sure that we drive this point home. And I just implore all our listeners, all our people in Africa to really realize that we actually are the people with the most to gain with vaccines because of our minimum, our small healthcare budget. And we have to thank every person who is out there donating into that pool of money that actually is there to help us afford these vaccines. Because without philanthropy, we will not even be able to get access to those vaccines anyway. And we need it. So it is not only just being available, it is being, affordable. So that's where we stand. So vaccines are the most, they have some of the strongest regulations around them. So people, once this thing goes through and the process, and it goes through, and the scientific community goes through a peer-reviewed article and come up and say, yes, this is safe. I think my people in Africa, first of all, would be the first person, at all time
to take it.
To take it. Yes. Yes, I would be the first person to
so
take
Dr. Edmund, ladies and gentlemen, this is a bi-weekly event brought to you by the Southern Cameroon Medical Society on this health literacy, seeking to inform and educate our people and hopefully answer your questions. Many of you who filed in your questions has informed some of this conversation and has helped shape some of the questions that have been posing to our discussants today. We invite you to stay present and decent. We always like to give you this 1 hour presentation on a bi-weekly basis so you can stay abreast and informed. To make sure that we crystallize what we're discussing today before we wrap up today's sessions, we would like to conclude with a few examples of vaccines and then put them in context for you. Because many of you have been asking what really informs the medical community to recommend for or against a particular medication or vaccine in a particular population. Because don't forget here, we've said certain things are going to be universal and some are going to be regional. So I'm going to be posing a few scenarios here to Dr. Edmund to use that to recommend. Is this going to be global? Is this going to be a universal thing? Is this going to be a regional thing? And if it is regional, which region would you recommend for or against? So starting out, Dr. Edmund, and just so you know, the last example will be COVID-19 if and when that effective example comes up. The first example, right, for Edmund, will be hepatitis B. You know, for statistics, sub-Saharan Africa has the majority of cases of hepatitis B. There is an effective vaccine which is the component of the virus. It would never cause the disease itself, but it protects people for life from ever coming down with hepatitis B. I recently lost a 35-year-old friend in the Cameroons from hepatitis B related liver cancer. What will you say? Hepatitis B, here is the vaccine. Will you recommend it? Which population will you recommend it to? Which population will you withhold it from?
Absolutely. I think the hepatitis vaccine should be universally, recommended. As you know, the chance, if you go past if you survive the acute phase of hepatitis B, then you may not survive the chronic complications of it, which is liver cirrhosis, liver failure, and ultimately liver cancer. And this is what actually kills the people. And luckily, WHO had actually included this in 1992 as part of that expanded program on immunization for the developing world. So everybody should get a hepatitis B vaccine. One of the problems is, so I think that they should get it because you never really know. It's an infectious agent that may be transmitted, in different variation and different groups. Here in America, we would really want to give it, target people who are like drug abusers and stuff like that and so on. But it's also knowing that people can also, contract this even at birth or through sex and stuff. It has to be something that people can, I would recommend it for everybody.
Thank you so much, Dr. Edmund. Ladies and gentlemen, if you just listen to us, we've emphasized the fact that hepatitis B is universal. And Dr. Edmund, actually, in the United States, every newborn baby is administered the first dose of hepatitis B before they leave the hospital. And so hepatitis B vaccine is a universal thing. Ladies and gentlemen, if you've not been immunized against hepatitis B, if you're listening to the Southern Cameroons Medical Society, go get vaccinated. Dr. Edmund, influenza, what we call in America the flu. So I know as a physician, you know it, but to our audience, influenza is an infection it's an infection caused by a virus. It's everywhere, but it's most notorious in regions that deal with the cold weather. Especially for us in America, it's typically around late September, October, peaking in the winter months, and then trying to die down in the springtime and summertime. And in Africa, because we live around the equator, we may not get it that much there. At least, Dr. Edmund, influenza vaccine presented to you. Where would you recommend this?
Again, this is something that, as you rightly said, if you are here in America and you don't have an allergy to or a previous reaction to a flu vaccine, You don't have an allergy to the components that is actually that the vaccine is mixed into. Here the risk really the benefit outweigh any potential risk that you may develop. So I would say go get it, because even though the mortality rate from influenza is far less, or the transmissibility, the what we call the R0, which is actually the number of people who could get infected from one person, carrying the disease, even though they are far less compared to some of these other diseases, I think you should get it, especially the older people, and then young kids, because these are people with weakened immunity, where if you contract this disease, or people with other serious medical conditions. So yes, generally the young and healthy, they may think that they are safe, but I've seen actually young and healthy people here die of flu. So, and if you are in healthcare, you should get it at least to protect your own patients, even not to protect yourself, because you could carry it and you are healthy, and you may not be able to, you may be able to survive it, but you go and give it to an 80-year-old or a 70-year-old or somebody with other medical conditions. Do you want to walk away with the burden in your mind that you probably caused somebody's death, even though inadvertently? I don't think anybody wants to do that. So yes, even if it's not as universal as the Hep B for some people, I would definitely say yes. I would say if you are somebody if you're older, if you're a young kid, if you have other medical conditions, and if you work in healthcare, please do get vaccinated by take your flu vaccine. And for every other person else, I support it. I actually encourage it. But if you don't want,
what if you are my grandmother at the Bamenda Regional Hospital?
So the issue there is just access, right? It's access and affordability. The problem is that's one of the problems that we were saying. But think about it. Yeah, flu in Africa, probably not as big a problem like flu here in the countries of the temperate regions with weather and stuff like that. So if there is, let's say you have 10 million, they give the regional hospital in Bamenda 10 million francs and say, okay, employ it on hepatitis B vaccine or on flu. I would say, okay, put that money on hepatitis. So here it's a cost benefit thing. But if it is available and people can afford it, I would give it to your grandmother.
Okay.
Yeah, because you have to realize that as we grow older, I'm also a geriatrician. So I know, like, as you older you get, your immune system actually wanes. And that's the problem. And these are the people who actually, if you look at the world, over 30,000 people who die in America yearly approximately from flu. Many of them are actually more from the older nursing home, and to some extent kids with a lot of and people with other associated medical problems. So that's why I would recommend it for them, unless they have other issues that may prevent them from getting it.
What if they've not really seen influenza in Bamenda for the last 10 years?
That's exactly what I said. That part of the problem why we don't see it is because we don't even test it. We don't even know that it exists, right? You don't even know that it exists. So that's what public health is supposed to let us know. What is the pattern of spread in that place? So we don't use all the money on things really there that should not really hurt anybody. I'm not saying you should don't import a flu vaccine from America only for your mother, for your grandmother. But
ladies and gentlemen, you're listening to the Southern Cameroons Medical Society give you practical examples of vaccines, and I would like to throw in a hypothetical example, because for time immemorial, us from Africa have had to deal with malaria, a well-known tropical disease. Dr. Edmund, tomorrow you wake up and there is a breaking news that an effective vaccine has been developed
that would
combating malaria. Where would you recommend it be used?
Oh, my God, that would be the most exciting.
Please, don't answer without always prefacing it. If there is an effective vaccine, I don't want our audience to be misinterpreting this answer.
Right. That's going to be the most exciting news that I get, if I get up tomorrow and I see that there is an effective vaccine that is actually like peer reviewed and agreed, and found to be effective and efficacious, and really has undergone all the levels that we've talked about, that I would be the happiest, because so many kids die or so many people die. I know personally how many days of school I missed. I probably sometimes miss like 1/3 of my school time because of malaria. When I was even right up to high school, right up to when I left. When I got to America about 20 years now, I've hardly had a fever that has kept me home from going to work. So number one, that everybody should get it. If in Africa, in America, maybe a different thing, because if it's almost wiped out here, almost, except you bring it from elsewhere, you almost don't have malaria here. So here will be a very low level. Yeah.
Ladies and gentlemen, you're listening to us really talk. Here we are, the medical professionals of the Southern Cameroons Medical Society, are informing you the reason we have never gone out there to say go get vaccinated against malaria, and this is because we have not seen any convincing data to make that firm recommendation. And the day we will see it, we will make that firm recommendation. And when we see the firm convincing data about hepatitis B, we have made that recommendation. And Dr. Edmund, I'm going to end with this next hypothetical example that's still hot on the press. We are hoping that in the next several months, we would have something that would be effective. If you wake up in the next 4 months and they say, here is an effective COVID-19 vaccine, what would you tell your patients in the Americas, in the Cameroons, around the world?
You see, in America, I'm not too much worried in America, because they'll force you to get vaccinated anyway. So that's the one thing that people are going to do. You're going to get vaccinated. But that said, I'm also very concerned that in America, I think the recent poll that showed about maybe about 20-something% of the people saying even if there was a vaccine, they won't get it. Part of it was actually the politicization of it. Some of it is the conspiracy theory and stuff like that. But I would say if there is an effective vaccine tomorrow, first, I would line up, I will miss everything I'm doing to go get it first. And I will get all my patients get vaccinated. And then in Cameroon, or Southern Cameroon, or Africa generally, please, everybody, I would recommend it for everybody. Number one, our health infrastructure is really, really so rudimentary that we really are even unable to take care of, the people that are sick. So even if you took a choice, if you took a chance and then you got sick, we could lose you. And so when in America, probably some people might say, yeah, I'll take my chances. Maybe there is a drug and stuff like that. But in Africa, very expensive. Number two, the infrastructures are not even there. The whole country, the whole of Southern Cameroons, I'm not sure whether we have one ventilator, So you must actually realize, even if you had a ventilator, do you have a pulmonologist who can intubate? Do you have other things? When you start intubating people and putting them up on the vent, would light just go off and that person will die because there's no light to actually. And even if all of these were available, why wait until it would just be penny wise and pound foolish to wait until you get into that situation. So my recommendation would be go get the vaccine.
Ladies and gentlemen, you just listened to the Southern Cameroons Medical Society discuss public health, discuss it in the context of vaccines, discuss public policy, and give you practical examples. Because one of the things we hate to do is to sit here and inundate you with medical jargon and medical terminology, and you go home wondering, how is this practicable in my situation? We hope by using these practical examples to review the context in which we made some of these discussions will help you use some of this knowledge for yourself, for your friends, for your family, and if you are a medical practitioner, for your patients, as well as for yourself. This is the Southern Cameroons Medical Society, hosted by Mr. Lambert Baum, the Executive Director of the Southern Cameroons Medical Society. I've been your host, Fausta Ditah. Excellent discussions today with Mr. Dr. Edmund Folefac and Dr. Edwin Shadzeka. Before we wrap up this today's discussion on the vaccines and public health, Dr. Edmund, do you have any general parting words for our audience?
General parting words: vaccines are so safe, they are very effective. Left to our own devices, we will not even be able to afford them. And we've been fortunate enough to have a lot of people in the international community philanthropists who have actually come in with the money and currently pouring in the money to expedite not only the vaccine development, but also the eventual procurement and administration to our people. When these vaccines become available, my people, you should be really, really there to go get a vaccine. Just be ready, go get your vaccine. And if you doubt, call us. We, as your own brothers and sisters, your kids, your parents, your brothers. So we really cannot deceive you on things that are not scientifically proven. So we are very, very happy to have had this discussion today, and I hope that this helps. And we can share. You can always contact us for more questions, and we can always come back if it's necessary. Thank you very much.
Dr. Edmund Folefac from the Southern Cameroons Medical Society. And ladies and gentlemen, you have been listening to this vaccines and public health presentation brought to you by the Southern Cameroons Medical Society. You can reach out and learn more about us by going to scms-global.org to learn more about the Southern Cameroons Medical Society. Submit your questions to us, submit your concerns to us, submit topics of interest to us so that we can make our future sessions useful to you, our audience, and to the wider Southern Cameroons community in general. It's been a pleasure being your host today. We look forward to having you attend more of our future shows. Thank you. Have a good afternoon, good evening, and good night. See you next time. Thank you.